To quickly review our agenda for today. Our forum today is to give an overview of our organization and how we partner within the community. We will review medical and clinical best practices, enhance agency and criminal justice system commitment, and most importantly, this forum is to give you the opportunity to ask questions. We want to hear from you. Brightview is a comprehensive outpatient addiction treatment center using clinical research and best practices to provide the best care for our patients. We have a continued focus on collaborating within the community and those stakeholders by partnering with criminal justice systems, working with the Adam H board, and volunteering our knowledge on MAT and clinical practices. At Brightview, we are proud to offer a 24/7 patient access center, online scheduling, virtual capabilities, and the ability to accept walk-ins Monday through Friday from 8 to 3 p.m.
I'm going to speak for just a little bit about the continuum of care for our substance use disorder patients. More broadly, I'm going to talk about why this is a necessary continuum in our communities, for patients with substance use disorder. Why we unfortunately don't have many areas of Ohio or of the country that have this level of continuum, and I'm going to talk about kind of the gap and need from patients from where we're at to where we need to be. So you can see on the start of the slide here, it looks like approximately about 1 in 5 patients actually receive the appropriate level of care, and 1 in 5 patients require inpatient care. Let me clarify a little bit on that. This continuum goes all the way from ongoing outpatient care, which is primarily what Brightview provides here on kind of the left of the spectrum, outpatient and intensive outpatient, all the way up to the most intensive level of care, which is inpatient. That the confusing stat that I just quoted is kind of a double whammy. Most people in the communities and in the environment and in healthcare, potentially even some of the folks in the field, really think that most individuals need a bed or inpatient care to initiate their addiction treatment, and that's just not the case. Both SAMHSA and ASAM have done years of research that show that actually it's only about 1 in 5 patients that require that level of inpatient care to be successful in their long-term recovery. And in fact, when patients are placed inappropriately in inpatient care, they actually do more poorly. That actually doesn't make much sense unless you really understand it. But to put it simply, if a person has stable housing and a stable job and are doing fairly well with their families and everything else, which there are those patients, and you take them out of that stable environment and plop them in 30 to 90 days of residential or inpatient care, when they get back out, their whole life is disrupted. So they actually do more poorly in the long run. ASAM does spend a lot of time and effort and resources on distributing what they call the ASAM criteria to help people understand what level of care individuals actually need. And that includes some criminal justice perspectives and strategies. And they actually have an electronic a version of that called the Continuum Engine, which is really neat. A technology that was developed a few years ago to allow folks to, even those folks who are not particularly familiar with ASAM levels of care, to be able to figure out where patients need to go. That's its own kind of hour-long lecture. I won't dive much deeper into that other than just to remind folks that, not everybody by any means requires inpatient care. The other 1 in 5 statistic that I quoted is where we're at in regards to the gap and why Brightview is growing to meet needs in several communities. And that's a pretty simple statistic. Only 1 in 5 patients actually get any sort of good evidence-based substance use disorder treatment. And that's opposed to most other disease states, cardiology, diabetes, et cetera, where in this country, we're fortunate that about 80% or 4 out of 5 patients gets the right level of evidence-based care that they need. And we track that through a lot of different metrics in our medical system. Just a couple of other points on this slide, and then we'll move along. Detox programs are something people commonly quote as a level of treatment. Detoxification or ambulatory withdrawal management is the more accurate term. Really is a part of the continuum, particularly for alcohol use disorder patients, But those programs, especially for opioid use disorder patients, are actually quite dangerous. And we've known this for probably 20 years at this point, where a significant publication came out in 2003 and talked about how people that were just detoxed, quote, detoxed, and then given a good luck, or go home and see how you do, actually had a high rate of mortality. So a lot of death related to just doing detox, and that's what you see in certain settings, such as when folks are not given the appropriate interventions while placed in a jail or a prison setting. Also, if they've gone into a hospital and not received the appropriate maintenance medications or detoxification and continuation of care. We do see these things proliferating, unfortunately, especially the hospital detox programs, without that continuum of care that we're talking about right now, there to catch the patient and ensure that they have long-term recovery. I already talked about what we do in 2 months, sometimes 6 months. And that for me was unacceptable given the fact that people were having overdose deaths every day. And there was a real disconnect between a life-threatening overdose and getting somebody into treatment for weeks to months at some point. So at Brightview, we've never had wait lists. We consider them to be unacceptable, and we do everything we can to ensure that patients can get in same day, next day, if at all possible, when they need treatment, whether it be referred from a criminal justice program or they decide themselves, or whatever the situation may be. Next slide, please. Just want to speak for a few moments about the medical component of our program. I think a lot of people know, but just to be clear, we're a holistic, or what they call a biopsychosocial program. That means there's three components, or three general components. Dr. Kane will talk a little bit more about the other pieces here in a second. It means we have a medical service, a psychological service, and a care, kind of a case management, care coordination, and a social service set. So those three are the buckets that we deliver to every patient. Not every person needs the same amount of things. They may need more medical, less clinical, vice versa, more social supports, et cetera. But it's important that when looking at treatment programs that you're referring to, that they have all three components available to patients that can be delivered on an individualized basis. Right now, I'm going to talk about a little bit again about our medical focus. And it's important because we know that this is really where the science is not being delivered in many settings to the patients and their particular needs. I was fortunate to participate in the Surgeon General's report that was released in 2016. It was a long time coming. Many decades had passed since the Surgeon General or someone of that magnitude or department had released anything that talked about alcohol and other use disorders. This is a very long report. The executive summary is actually quite a bit more digestible if you're interested. But in general, it talks about the fact that the data, the science, the research shows long-term use of maintenance medications, and I'll talk about those in a second, successfully reduces the things that we all care about. We want people to use less drugs. We don't want them to relapse and overdose. We don't want them to continue criminal behavior. And of course, we don't want them to transmit infectious disease to others, which is both deadly and expensive. The types of addiction medications that we use in our practice are primarily the FDA-approved medications I'm going to talk about for opioid use disorder, but we also use other addiction medications for alcohol use disorder and other use disorders. We also do have utilization of what we describe as off-label or not yet FDA-approved medications when they're indicated for different things. I won't go in depth, but for people to understand, that's not an uncommon practice for medical practitioners, physicians at all. A lot of medications don't ever get tested on different populations for different reasons, and therefore don't receive FDA approval. We are, however, I know this is an important point for a lot of folks. We are, however, working with the FDA. I'm on a panel with them to work on getting FDA-approved medications for stimulant use disorder, as we're seeing, methamphetamines, cocaine, et cetera, particularly methamphetamines, really resurging and causing a lot of devastating issues in our communities. You can see here some of the medications: buprenorphine, naltrexone, often known as Vivitrol when we're talking about the long-acting injection, and methadone, are three of the primary medications that we use for opioid use disorder. We follow the research on these medications very closely. We have a huge team of board-certified addiction specialists, experienced advanced practitioners, including nurse practitioners and physician assistants. And we all constantly read and monitor the research and require to do so. in order to continue to practice in a way that is both medical legally compliant as well as consistent with our Hippocratic oath. What I mean by that is that a lot of folks don't know, but we are required to, by the oath that we take, to do the best for our patients. And that means whether it be choosing the right medication, the right dosing, other therapeutic interventions, referring them to other services. We're required to do all of that stuff by both our oath and the fact that if we don't do those things correctly by the evidence, if we were to have a bad outcome, our medical legal liability is quite high. One of the important points of that is the only things that can affect our decisions that we make in regards to medications that are chosen, the duration, the dosing, are the science and the physician-patient relationship. There really is not any place for other outside influence in regards to what's chosen because there's no protection. So if let's say, Bob Smith's mom tells me she does or doesn't like certain dosing or medication, whatever else, I can't really regard her opinion on the topic because there's no medical legal coverage to say, well, Bob Smith's mom told me she didn't like it. So I'm just giving that as an example of something that's a little bizarre to this field because I've never had that experience in the rest of medicine. I've never had somebody's parent tell me how much insulin they should or shouldn't be on or whatever all else. So we are literally bound by appropriate constraints, sometimes legal, that require that we do choose the best medication for the patient, given all the factors. And that can include whether they may or may not be in a situation where diversion is a problem. And we may choose to use something like Vivitrol or Sublocade, which is an injectable form of buprenorphine, so that there's no risk of diversion and no way that the patient could actually misuse the medication. Finally, I will remind folks, again, there's other medications for other use disorders. We actually at Brightview do a lot of work in smoking cessation. Every medical practice really should do that work, but we specifically focus on it because our population has a very high rate of tobacco use disorder, smoking, dipping, et cetera. And somewhere in the neighborhood of 75 to 80% of our patient population has that issue. And so we have a consistent review of patient smoking habits, as well as putting them on the appropriate medications, which may be something like Wellbutrin, which is an antidepressant, also in conjunction with nicotine replacement and whatnot. I hope that at this point you understand we spend a ton of time making sure we're doing the right thing with our addiction medications, as we should do, as every practice that is treating patients with addiction should do. And if you're referring patients to a practice where they barely have a medical practitioner involved, I hope, again, that it's clear it's not really possible to do the level of appropriate intensity and understanding on the types of addiction medications and how they should be used. Next slide, and we'll turn it over to Dr. King to talk about his section and his team.
Thanks, Dr. Ryan. So as Dr. Ryan indicated, we've got hundreds of years of experience with our medical team. It's such a vast wealth of knowledge as it pertains to the delivery of our medical services. The clinical team is similarly constructed, more counselors, case managers, and peer recovery supporters. So I think that ends up leading to us having thousands of years of experience in addiction treatment and behavioral health care delivery on the clinical side of the house, but it's probably just informed by the larger numbers of the group. But I think important for this group to understand, what are the services we provide? So individual therapy, group counseling, case management, and that also, we like to include family therapy, or at least family education if we can, if that's available. So we really look at the comprehensive set of psychotherapies to try to deliver to the patient and to their system. From a social service standpoint, our facilities offer case management services and peer recovery support. We like to think about those as evolving needs over time, in that a patient may have one set of needs when they first come to us: transportation, housing, food insecurity. Obviously, we need to address those in order to adequately stabilize someone, but then really also want to work with folks in the long term on some higher order goals that they might have when it comes to education or getting ready for a job interview or application process, having a resume, the right clothes, even some of the right skills to be able to navigate that process. So really wanting to work with folks in as comprehensive of a manner as possible, and then partnering with other treatment adjuncts in the community, supporting patients in their connection to AA, NA, Smart Recovery, Celebrate Recovery, what have you. So we really look at our model as being as comprehensive as possible, and look to deliver not just the medical services, but the clinical services in-house. Each of our clinical teams is led by an independently licensed master's degree clinical supervisor who's on site every day, oversees that team, oversees their quality, sits in on their sessions to ensure that the interventions we're delivering follow the evidence-based guidelines that we have developed and that we utilize from the literature. And also that supervisor conducts group and individual supervision with our teams every week. And those supervisors are trained by me and by our clinical leadership team. We meet at least once a week to do that. And then I also join our treatment teams and group supervisions on a regular basis. I've got one here later this afternoon that I'll be connecting with that team via this type of modality. So really nice that we can use some technology to support the teams in the center, but they're also independently constructed such that that team is supervised and the quality of their service delivery is managed on a local basis as well. A quick note about harm reduction. I think I'll talk about it from the lens of inside of our centers. Dr. Ryan made allusion to like how we think about harm reduction in the community as it pertains to mortality reduction and reduction of infectious disease transmission. A note for everyone who's listening, how do we practice at Brightview? If you're a justice system partner, how do you interact with us? This is one of those things that I think is important for us to talk about. We really operate with a harm reductionist or what we call a non-punitive clinical philosophy, meaning that we really want to continue working with our patients regardless of how the ups and downs of their recovery process manifest, right? So folks may be at times relapse, they may use one substance while successfully abstaining from another. And what we want to do is work with folks in the long term, understanding that the development of their substance use disorder, the natural progression of the disease oftentimes takes years. And so treatment is not necessarily going to be like a light switch where tomorrow the person is cured, as it were. Instead, we really look at incremental progress. Are they safer today than they were yesterday? Are they better tomorrow than they were today? And making those incremental pieces of progress is really how we get to the end goal. Now, some of these gains can be made quite quickly, and we've got a slide that I'll talk about here in a second as it relates to our outcomes. But I think our idea of treating folks with dignity and respect and treating patients with a measure of grace as they endeavor to achieve their goals is important. So we would never fire a patient from treatment for struggling with the condition for which they're seeking our help. We don't have 3 strikes rules or 30-day blacklists or that kind of a thing, or you've been here too many times, you've got to go somewhere else now. We really like to be there for our patients in the long term and understand that our centers are a haven. So if someone's got the urge to use or cravings or that kind of thing, rather than calling an illicit party or that kind of thing, they can come to Brightview unannounced, walk in. You don't have an appointment, it doesn't matter. Our team's here to take care of you and meet you where you are. Next slide, please. A few notes about virtual care coordination. So the idea of telehealth has obviously expanded in the past year thanks to the pandemic. The good news for us at Brightview is really that we've been doing telehealth for a couple of years pre-COVID. And so for us, it really wasn't about figuring out the technology. Instead, it's been more about how do we develop adequate rapport with our patients and foster a sense of connection when we're using this modality. So Dr. Ryan and the medical team, myself and the clinical team, we've been doing quite a bit of observation of our telehealth care delivery and education around that. Like how do we do this in a way that patients still feel connected to their clinician, or if we're doing group therapy in this modality, which we do offer, how do patients get a sense of cohesion with one another, knowing that a sense of connection to other group members is actually more important than a sense of connection to the facilitator if the patient's going to stick with group therapy and derive all the benefits from that. So everything that we can do in person from a medical and clinical standpoint, we can do via telehealth. Obviously, as it pertains to urine toxicology and blood work, can't do that remotely. Many of our centers also have an on-site pharmacy. We don't have one yet in Richland County there, but we will here in a few months. And obviously, that kind of thing can't be done remotely. So the vast majority of our visits continue to happen in person, and that's actually mostly driven by our patients wanting to see us and wanting to see each other. I think that there is a necessary piece of just like the human condition, where literally being seen and heard live is important to folks. So over 85% of our visits are still happening on the in-person basis in our brick and mortar facilities. But the idea of us having telehealth as an option to overcome barriers to accessing treatment is really, I think, a special thing. And overall, we weave technology really into everything that we do. So on the screen, you'll see some notes about our online scheduling ability. I think for me, when I was in the hospital system, this was one of the most frustrating aspects of having patients access addiction treatment. As Dr. Ryan said, the time to get patients into treatment could be 2 months. But there was also this other notion that most addiction treatment providers required the patient to get on the phone and prove that they were motivated before they would get an appointment. And so we don't require those kinds of steps at Brightview. So our online scheduling tool allows you to schedule on behalf of a patient. So if you're a probation officer, if you're a court administrator, if you're an EMT in the field, if you're a social worker or a discharge planner in a hospital or whatever, if you've got someone in front of you, in other words, who needs an addiction medicine appointment, that appointment can be made before you walk away from each other. That can happen through our 24/7 call center. That can happen through our website, where the patient or the prospective patient gets onto scheduling.brightviewhealth.com and fills out the form there to get an appointment. Or again, you can do that on behalf of a potential patient. What's really nice about that is that when that is done, you know where that patient is going and when they are supposed to come to our center. We can also do the release of information online as well, completed via DocuSign. So before you send a patient, you could also have the ROI done. And so you already know that Brightview can communicate back to you about how that patient is doing, and the patient's already agreed to whatever can be shared. But what's really also just nice on a human level is when that patient walks in, we know that that they were coming. And I think folks with SUD are rarely treated with that kind of anticipation or with that type of respect, that when the patient walks in, we already have them on our list, never seen them before, but oh, hey, we're glad you're here. We were expecting you. Obviously not necessary. We would treat any patient like that. But I think a nice touch that really adds to the experience. Our ability to take walk-ins just informs our practice that we would do that kind of thing anyway, but really nice to jumpstart the treatment process. And again, if you're someone who's referring a patient, really nice to know exactly when that appointment is and when it's supposed to happen. If the patient doesn't go and you see them again, you can also ask about that, because you knew that there was this discrete appointment that they had scheduled with us at Brightview. Next slide, please. So folks oftentimes ask us, does this work? I mean, hopefully it's apparent that we endeavor to be the premier SUD treatment provider in the community, right? And we seek to bring a level of service for years to come. We are not a fly-by-night operation. We seek to deliver a level of service that frankly is all too uncommon in the field. But I think a fair question is, does it work? And so I won't read the slide to you. There's a selected set of metrics from our outcomes analysis that we've been doing for the last several years, produced here. And basically what we sought to do was determine the question, frankly, for ourselves: how effective are we? And what are the gaps in our quality? How can we do better for our patients? Because there's always ways to do better. Addiction is a complex condition. The intervention set that we're delivering is complex. In order to fully understand our impact, we have to do a very multidimensional evaluation of how our patients are doing. And that's what we sought to do. So in looking at almost 12,000 Brightview patients now over the last 3 years, we understand that we are able to make a very dramatic impact on folks in relatively short order. So you can see some of the time frames on the slide here: 3 months, 6 months, very substantial change that patients experience across their experience of the world in all these different ways that we can measure. Much of this data has been verified by some of our payer partners and also through other third-party claims databases. And so very exciting to see the dramatic impact that we're able to have. For any data nerds that we have on the line, we're looking at p-values with like 14 zeros on them. So that's a pretty compelling set of relationships between Brightview treatment and the outcomes that patients are able to achieve. Less depressed, less anxious, sleeping better at night, using the hospital less for emergency and acute care, psych, and medical, getting arrested less time in jail, getting off probation, getting their kids back. These are all the kinds of things. Obviously, using substances less, should probably mention that as well. These are the kinds of things we really want to change every patient's experience of all facets of their life. To me, the most important thing too that we've been able to get out of this is to give patients clarity. So in order to get there, what type of engagement do patients need to demonstrate with us? How many counseling visits are necessary to achieve these kinds of outcomes on average? How many medical visits? That dose effect response, that's a technical term for what we're talking about, type of analysis is one that hasn't really been done much in the field before. If it has been, it's been done at a very small scale, a couple dozen patients or that kind of thing. Again, almost 12,000 patients who we look backwards at in time using a natural observation structure to say this is the type of treatment engagement that gets to these good outcomes. And we can provide that clarity to our patients, their families, our referral partners, and frankly, to ourselves, so that we have a strong degree of confidence that we're delivering something that impacts people for the good. I'll throw it over to Nate. He'll talk a little bit more about some of the pieces that I referenced around communication, jumpstarting treatment, what you all can expect from us in terms of coordinating care.
Thanks, Dr. Kang. As Dr. Kang, had talked, and sort of the general theme there is Brightview is committed to continuous improvement and understanding that as we grow, we understand there's a responsibility that there are new insights, new communities, new ways of doing things. And as we've adapted our actual direct service lines, as both Dr. Ryan and Kang had mentioned, whether it be dealing with just standard changes or dealing with an unexpected event like COVID-19, it's just part of our DNA. And what we also integrate into that is at the local level is understanding that part of having a great service is having great partnerships, and in understanding the different circumstances that are driving our patients to treatment, or some of the things that are going to be attributed to their success beyond just what we can provide them in services. And there is no population that is, I think, more that brings more awareness to this than those that are integrated into the criminal justice system. We really believe, and what we actually really not believe, what we know, is that this is more or less a co-occurring circumstance. The criminal justice system, as many of you are involved in that, has adapted in a great way to understand the needs of these folks and what's driving not only how well they will do post their whatever their circumstances are in the criminal justice system, but that the treatment aspect for those who are suffering from addiction and co-occurring disorders is a huge component of that. We needed to bring that more into our company. So over a year and a half ago, we really looked at what do we need to do better, to better understand those partners, particularly in the criminal justice system, and how we can make sure that we are improving our communication and our accountability, which were two of the main drivers that we determined through several surveys that we had room for improvement that would also not only benefit us, our patients, but also all of the partners and how they integrate with our services. So that is the essence of our system that we ended up building, really based off of improving communication and accountability. That's what we heard from all of you. That's what we heard from our own providers. And in two very distinct tactical ways that we can do that is ensuring that the information is what you need and then provides you a good understanding of where the patient is so you can make decisions as well on how to manage their criminal justice status. And then the other component of that is, well, when you need it, right? Patients come to court on certain intervals. They're engaging their probation and parole on certain intervals. And the best that we can do, the more that we can understand that and improve our service of getting that information when you need it was, really the two components that are based off of what we call our criminal justice process. So within that, what we learned is that as we are in many different sites, since we didn't have a real standard process, that our sites were doing what you would expect them to do. They were creating their own. And for us, what ended up happening is you have 30 to 40 sites, it became really, really difficult for us to determine how well are we serving these patients that are involved in the system and the partners that are integrated with that when you have 30 or 40 different ways of doing it. Now, we will customize based off the needs, but we really wanted to find is there a mean or central system or timing that would work more or less for most people? So what we found is that if we could get reports with the right information out there every 2 weeks to all of you, there are partners, that more often than not, we were hitting the nail on the head. Oftentimes that was more frequent than what they needed. Again, certain circumstances, we will always prioritize our relationships. We could customize that to be more frequent if needed. But really, we found more than 90%, more than 95% of the time in Ohio, that we've been successful with a 2-week reporting system. So we built an organization around that. Thanks to Dr. Kang primarily working with me to think through this, we created a new position called the case management specialist. And that person is a very seasoned case manager. So I'm robbing Peter to pay Paul, and Dr. Kang has appreciated that. Not appreciated, but also appreciates the need for that. So we will take them from a person that's interested in the position, because we want to have the best and most experienced people on how we do it in those positions. And that position is a regional based position. So we have a case management specialist that more or less will own anywhere between 5 to 8 sites in a region. And they will be responsible for all of the reporting and accountability of the patients at their sites, and really provide that direct best in class service to all of you, to make sure that your needs are met and that we get the information out there that you need and when you need it. So another key I'll mention here, that's 2 other things I'll mention. One is what we also realized is that we only had the ability to track patients that were referred to us in criminal justice. We didn't really have a mechanism to really determine, if someone was criminal justice involved, unless they were referred. But what's to say a patient isn't coming from the hospital or walking in or from another partner that could also be involved in the system? So providing the service is one thing, but also identifying those patients is another. So long story short is we've integrated that into our medical records and updating them the treatment plan. There's a mechanism to ask that question, so that we're actually identifying all the folks and have a way to identify all the folks that are involved, and then to really convert them to getting into the reporting system. The last point I will make is that we also know that the release of information can be a really difficult and sensitive topic. We don't just want to give a release of information to a patient and say, here, sign this because you need this. We have really made this a clinical intervention to express why the patient should sign this, why it's important for us to represent their needs, and why it's important to continue to build trust with us. But all of those, parole, probation, and core systems that will ultimately, determine and help them determine their success longer term. So, long story short, we've got, we want to make that process easy as well. So, Miki will work with you. We have, an outreach team that, I think complements our case management specialists and the relationship building, where all of this is on our website. It's very easy to use our referral system online, but also the ROIs are there so that we can get those signed in a timely manner and make sure the information is correct so that we provide that service. So within that, you can see there's Dr. Kang's, the results speak for themselves. We've seen incredible feedback, not from all of you as far as the service that we received from our net promoter scores and all of that, but also we're just seeing it in the data from our patients, and how they're engaged less in the system or relapsing less in the system as well. So very excited. And last but not least, I'll turn over to Miki, is that we are continuing to improve. So we look forward to your feedback. This forum is for that as well. But if you have any additional feedback later, don't hesitate to send it through to us, probably through Miki, and we will look to continue to improve. We've gone through 5 iterations already. So what's a 6th? Thank you very much.
Thank you so much, Dr. Ryan, Dr. Kang, and Nate. I want to say I'm truly amazed and grateful that in one of the previous slides, it said that 99% of our patients at Brightview say it's working. What a huge accomplishment. Now we'll talk about importance of feedback. We actually use the NPS or Net Promoter Score that lets us know how we're doing. So your feedback is very, very important. You may receive emails or a text asking how Brightview is doing. It is a fast and easy way to gather and understand and act on the partner feedback, the responses that you give. It allows Brightview and our employees to recognize how we can become better. It helps us assess how well our team is doing and how well our processes support our stakeholders. It also allows us to identify critical resources for improving relationships, services, and processes for referral partners like yourselves. Most importantly, it gives our patients the opportunity to let us know about their experience. Next slide. We've had many great conversations with a lot of you individually. I know myself has, but one of the ideas of this forum is to share best practices and learnings. Please feel free to unmute your mic at this time and chime in and ask any questions that you may have. Does anyone have any questions? I do have a few that's popped up prior to registration. I can go ahead and address those. And if you think of one, please feel free to type it in the chat or let me know after we get these first couple answered. Here's the first question. How are mental health issues addressed and are services available at Brightview?
I'll take that one. So we are very fortunate to have the team that we have in that our physicians, nurse practitioners, and PAs, our counselors, our supervisors, they're not only experienced in addiction medicine or in addiction treatment. Our counselors come with a background in mental health care delivery, having worked in community mental health and a variety of other settings. Again, same with our social workers. Our physicians, many of them are double and triple board certified, having worked in hospitals, emergency rooms, as OB physicians as well, right? So our ability to subspecialize and treat our patients is pretty broad, actually, when you zoom out and look at that capability. And I think most of us can appreciate that regardless of your practice setting, you will encounter folks with severe and persistent mental illness or just behavioral health concerns across the board that are non-SUD related. So we endeavor to take care of about 90% of our patients' mental health needs at Brightview. The patient has to have a primary diagnosis of a substance use disorder based on our license as an addiction treatment provider. But I think our teams are pretty robustly equipped to take care of most of those needs. For the smaller subset of patients where we begin to feel like the care that's needed is more complex, for that 10% of patients, let's say someone who has schizophrenia or bipolar disorder, and our provider team needs some assistance there, we look to refer those patients to other providers in a co-management type of arrangement. So we may have a psychiatrist who's taking care of the patient's schizophrenia in that case, but we're still providing all of our services as it pertains to addiction treatment, addiction medicine. In the next year, we may look at developing our own internal psychiatric service line. That's been something that Dr. Ryan and I have talked about for a while now. When is the time right has really been more of our question rather than if we should do it. And just given the overlap in the need, that's likely something that we'll pursue here in the near future.
Thank you, Dr. King. Another question, best practices for treating those struggling with methamphetamine use.
Thanks. So as I previously stated, we are working on advances in regards to FDA-approved medications to address methamphetamine use. It's a necessary issue. It can be quite challenging to get people off methamphetamines. For those that don't know, methamphetamine actually spikes the pleasure hormone dopamine stronger than any other drug. And so that is one of the reasons it's so addictive. But in current state, we also have longstanding evidence-based interventions called contingency management and other therapeutic interventions. These types of interventions have long been a part of Brightview's program for all use disorders, but also specifically for stimulant use disorders, and have proven to be effective in regards to addressing those issues as best we can. There's also some research supporting both naltrexone or Vivitrol as well as buprenorphine in these, but again, not FDA approved yet. And some newer research talking about a pretty interesting technology where we use magnets to affect certain waves in the brain that can actually reduce the desire for stimulants, particularly cocaine. So a lot of stuff going on. We again will use the already evidence-proven interventions that we know to be at hand. We will use things appropriately as they come along by new evidence, and also work to get new things delivered to our patients so that we can better address stimulant use disorder.
Thank you, Dr. Ryan. One last question. How has or what best practices has Brightview put in place to work locally with the mental health and Adam H boards in the communities?
I think Dr. King and I can both address that a little bit. We've continued to collaborate with any and all mental health and addiction boards that are willing to do so. Dr. King and I both serve on the Recovery Ohio Council, which is a new entity created under Governor DeWine in the past couple of years. And there's a lot of collaboration and coordination with those entities through that, as well as through OACPO. I'm sure a lot of folks are familiar with that team. And we'll have, actually I talked to the board director in the Piqua area this morning about some needs and ideas that they have there. So myself included, I have a staff member named Dave Rich, who is really reaching out to a lot of the boards to make sure that we're meeting with them and providing any interventions that we can in the community, up to and including things like significant naloxone distribution, if that's something that the community board is interested in. We've actually put on the largest naloxone distribution in the United States that's ever happened, along with Hamilton County Public Health and the University of Cincinnati a few years ago. So we have those skill sets, we have those interests, and really promote the conversation to see what any county board would like to do and how we might be able to partner with them. Dr. King, anything else?
I think the only thing I would add is that even before we opened our Mansfield location, we connected with Joe at the Mental Health and Recovery Services Board to talk about, what are you guys seeing in Richland County? We talked with a bunch of folks between the Sheriff's Department and Mansfield Police, and also the Probation Department. But specific to the question around the Mental Health Board, we like to make those connections even before we open our center, or even before we sign a lease in a building where we're going to do the construction and build our center and everything like that, because it's important for us to have those good connections. Sometimes funding is available to support some of the services that we provide to indigent county residents. Sometimes it's not, but I think ultimately, again, as we started this conversation, it's important to have a good sense of what's the community need, where are the treatment gaps, and how do we get folks connected to treatment with a sense of urgency. And the Mental Health Board is typically a tremendous resource in that regard. So, for my part, if anyone knows that system at all, like Dr. Ryan and I have worked closely with parties in that public system in Hamilton County and Claremont County and a bunch of others. And as Dr. Ryan alluded to, some of our centers have a very close connection to our mental health boards across the state. I see that Tom's asked a question for law enforcement. I think it probably applies to anyone. Do we have any collateral that we can provide to police officers who they can carry in their vehicles or otherwise, share with prospective patients? Yeah, Miki can provide whatever you would need. I see business card size would be perfect. I figured it might be. So I've actually got one sitting here. So we've got some pretty handy ones that has the Brightview website and our 24/7 call center number. Again, if you respond to an overdose scene as law enforcement, as part of a group of first responders, whatever it might be, you can walk away from that interaction with the patient having an appointment in hand, which I know from my friends in fire and EMS and police here in Cincinnati, that's been one of those things that in the past was so demoralizing. I keep going back to the same house and I don't feel like I'm doing as much as I could. What else can I do? And it's how about you can walk away with an appointment in hand? Let's create that system. That's where a lot of these ideas came from, is that those systems didn't exist before, right? And we've got to have resources like that out there, and would love to equip your team with that kind of stuff. Thanks for the question.
I will ask again if anyone else has any more questions. If not, we will move forward.
I do have a question, Miki. My name is Robin McNulty. My screen shows Elizabeth, but I'm Robin McNulty. And I am the student advocate and community health worker with Madison Adult Career Center. First of all, I've already spoken with you, Miki. You did a great job with letting the community know about your services, and we're so grateful to have you, to have Brightview here in Richland County. Much needed. So thank you, everyone. We're so glad to have you here. I'm wondering, are you currently familiar with working with community health workers like in Cincinnati, Columbus? Yeah. Okay. All right. I'm seeing some nodding. So, because we have quite a few community health workers in Richland County. And so you'll probably be hearing a lot from us. So I would love to, at some point connect someone with the CHAP hub here locally so that you could speak directly with all of our community health workers and let everyone know what's going on. These are great services. So don't really have a question. I just wanted to thank you so much for what you're doing in our community. Thank you.
Robin, I wasn't aware that you guys had a community health worker contingent in Richland County. I don't need to tell you, there is a wealth of literature supporting the critical nature of that intervention set for folks with behavioral health conditions across the board, not just with substance use disorder. So that is very exciting, and that is a critical organic connection that our teams need to have on the ground for sure. I mean, like your CHWs are seeing folks in vivo, right? And making that connection to needed care, whether it's behavioral health or physical health care, key connection. So thank you for that.
Thank you so much. And Miki, I'm sure I'll be speaking with you, trying to set that up. Thank you.
Thank you, Robin. Absolutely. I look forward to that. Does anyone else have any questions? We'll move forward. Supporting you guys locally, it is our goal and our main objective to definitely work and partner with all of you in this community, criminal justice, the mental health boards in general. It takes a community to band together to make life changes, and that's what we will work for and strive for here in Richland County. So we depend on you as well as community resources, and we would love the opportunity, if you've not met or spoke with myself, to please reach out and let me know how we can work together and change and save lives in Richland County. Next slide. One thing I want to say is that there are 3 ways to refer. I always say it's the easy as 1, 2, 3. You can call our 24/7 hotline. You will be able to speak to a live access specialist at 833-510-4357, and they will be able to get a patient scheduled that day, as well as go online to brightviewhealth.com. Again, you can utilize all those 2 features to have that appointment scheduled right then and there for a patient. And that's accountability. They have that. So sometimes that is what is needed. If we give it back to them to schedule themselves, sometimes that does not happen. So it's easy for you to go ahead and utilize those 2 tools, as well as walk-ins. We accept walk-ins Monday through Friday, 8 to 3 here in Richland County, and at all of our other sites as well. So again, it is easy as that, and as easy as 1, 2, 3. I actually heard that from a provider's office, so it does work. Accessing Brightview, I will review that again. It's our 24/7 access line, 833-510-HELP or 4357. Online scheduling, and walk-ins are welcome until 3 p.m. Dr. King briefly touched on this. Our on-site pharmacy isn't open yet, but it will be opening soon, and we look forward to that. And we just want to do treatment on demand, meaning there is no wait list. We are here when the patients are ready. At this time, I definitely want to say thank you so much again for taking the time out of your day to join us for this forum. I hope you found it beneficial and helpful. And thank you, Dr. Ryan, Dr. Kang, and Nate. I appreciate your time as well. Again, I'm Miki Zeigler, the outreach manager for our Mansfield site. My contact information is listed on the screen below. Please feel free to reach out, contact me, email, text, call. I'm here to be a service of Richland County, Mansfield area, and surrounding counties. I'm boots on the ground, want to get involved, roll my sleeves up, and help you as we make a difference in the lives of those we serve. And again, serving people, saving lives. I want you to have a safe day, and thank you again for joining us.
Thanks, everyone. Have a great day.
Stop.